If you're a physical therapist, you should be using subjective intensity in the clinic to make sure that your exercise prescription is on point. Now let's first go through what subjective intensity is. Now the two most common things are going to be RPE and RIR. RPE is a numeric way to measure proximity to failure or how difficult something is in the programming and periodization world. Now it goes from 0 to 10, 10 being an absolute banger, cannot do any more effort in any sort of context, and 0 being like laying on the floor, cannot possibly do any less activity. And so if we look at RPE, which stands for rate of perceived exertion, it is exactly what it sounds like, is subjectively, how are you perceiving the exertion levels that you're currently doing with the exercise. If we were having somebody do a back squats with 100 pounds for a set of 5, we would want to know how difficult they are rating that on a 0 to 10 scale. And so if it was pretty difficult but not super difficult, we might land at like a 6, which is 4 steps away from a 10, which is again the high end of the spectrum, which is I could not do any more. And so if they rated something out of 10, that means that there can be no more work done. I can't do anything else with this context, with this rep range, with this movement range of motion, with this weight on the bar, what have you. Now RPE came from, I'm sure a lot of us have been through exercise physiology classes, the Borg scale, which was developed by Gunnar Borg, and it was a, if I can recall correctly, a 6 to 20 scale that coincides with or correlates to heart rate. And so if somebody rated as they were doing some sort of aerobic exercise, it was at a 6, then ideally their heart rate would be at a 60 beats per minute. In the most simple essence, RPE is just a 0 to 10 way to measure the difficulty or how close to failing you are when it comes to any sort of exercise. Now the other subjective intensity that we hear a lot of is RIR, or reps in reserve. Now, there's a little bit of debate as to whether or not these two are interchangeable, reps in reserve and RPE. I kind of tend to think that they are interchangeable and that they are inverse related. So RIR works like RPE in that it is a measure of subjectively how close you feel like you are to failure or how difficult it is, but more so in a sense of how many reps you have left in the tank before you cannot do anymore. And it's the same thing, it's a 0 to 10 scale, numeric scale. If you rate something as an RIR 0, meaning you are at an absolute max, you have no reps left in the tank, 0 reps left in the tank. And if you were to rate something at maybe an RIR 3, you would have 3 reps left in the tank. And again, this is subjective, so it's kind of like I'm guessing, I'm taking an educated guess as to how close I am to getting to this number or to this sort of idea. And so they're both subjective, and they really come into play when we're working with patients in the clinic as we're trying to instill more intelligent programming and intelligent periodization and making exercise plans that are maybe more well-rounded. Now, the first reason that you should be using subjective intensity with your patient is that it fluctuates with the person. When we're thinking about performing, when we're thinking about exercise efforts or physical activity efforts, there is a daily fluctuation that happens. I'm not the same person that I was yesterday, that I was last week or a month before. And so to use the same, let's say, intensity prescription objectively, where I was to prescribe a certain weight to somebody, I might not be the same person that I was the last time I did that, and it might be received, and it likely will be received differently by my person. Most of the time in the clinic, we see folks are doing 3 sets of 10 of 5 pounds until their discharge, or 3 sets of 10 of 10 pounds, or what have you. Now that is still an intensity prescription, right? We're telling them how difficult we want the movement to be, but it does not take into account the fluctuation that they're going through. And especially in a rehab setting, as we start to modify symptoms, as the symptoms get better or worse, there's going to be different ways that they can produce force or that they can kind of interact with a performance. We want to give them that room to kind of wiggle, to kind of move while we are trying to help them get towards that meaningful activity return or get back towards the goals that they are looking for. If we were to marry that weight or just give them the same weight to do every week, then there's not really any of that wiggle room to kind of account for their daily fluctuation. Number 2 is that it allows us to make sure that dosing of training is appropriate. In the clinic, as we're starting to get into writing more intelligent programming and more intelligent exercise plans, we want to make sure that dosing is appropriate. Being in the clinic kind of lends itself to a little bit of fuzziness. While we are taking somebody who is not in their usual element, where they are having an acute injury or they're having more persistent pain or there's something that they're not in their norm for, it makes it a little bit difficult to figure out what their activity level is. And so we have to kind of divorce ourselves from the idea of this is as much as they can tolerate in a performance standpoint, and this is as much as they can tolerate on a symptom standpoint. And when we get wrapped up in trying to objectify things or trying to say like this is the dosage that we're going to do, things get a little bit wonky because they have symptoms that are present, or they might have not trained in a long time, and so they might have deconditioned since then. And so when we're trying to make an appropriately dosed plan, it helps to have a subjective feedback, whereas we can say, hey, is this difficult? And they can say, yes, it is difficult, or no, it's not difficult, but it hurts, or it doesn't feel good. And so then we can kind of change things around, again, a little bit of that wiggle room as we are interacting with them. Now there's two different sides of this coin. We don't want to underdose them, where we're saying we want to do 3 sets of 8 with 5 pounds on a squat. And if they are a, elite level power lifter, if there's somebody who trains CrossFit or who is stronger than a baby, and we don't want to go on the other side of the coin where we are giving them way too much. We might sensitize their symptoms. They might not be able to tolerate that. And so using a subjective intensity or subjective rating scale in the moment can help us to narrow down where we're landing as far as the exercise prescription goes. The other part of the second point of appropriate dose training is that when we use the subjective and we can tell that things are getting a little bit too difficult or a little bit too easy, we can avoid the negative connotations that come with either failing a lift or giving somebody something that is way too easy for them. And the negative connotation or the negative consequence of that is that if we give them something that's way too hard, it could sensitize their symptoms, or they could just fail the lift. And there is, fatigue associated with failing a lift, especially if we are at like an RPE 10 or an RIR 0. It's just a fatiguing thing to experience. But not only that, if they fail a lift, then they are having some sort of mental aspect or psychological negative outcome from that, because they're like, oh my God, I'm worse off than I thought, or I'm not at the level that I thought I was, or I can't even lift X weight, or what have you. And so we kind of avoid that end of the spectrum, and also the other end of the spectrum, which is, oh my God, I can't, my physical therapist is giving me 5 or 10 pounds to lift. I'm never going to be able to get back to the level of performance I was at before. This is awful. I'm like a grandma strength-wise, or a baby at this point. And so it avoids those two extremes, and we can, again, try and hone in on that happy medium as to where we should land when writing exercise prescriptions for patients. Point number 3 is that it takes out the need for any sort of max testing. Now, if you're new to the exercise prescription world, max testing is where we take somebody and we put them in a specific context and we try and see how much they can do in that context. Max testing can be 1 rep max testing, where we say we want to take a back squat up to 1 rep max and see how much weight you can do at that point. Or aerobic based testing, where we say, all right, we're going to do a 2,000 meter row and I want to see how quickly you can do that. It can be 5 rep max testing, where we say, I want you to do as much weight as you can for 5 repetitions. Or it can be something as high as 10, 20, 30 rep max, which sounds awful, but the idea of max testing is that we're taking somebody and kind of drawing a line in the sand to see where it is that they're landing, so that we can then make decisions for their exercise programming after the fact. In the rehab space, we are seeing people when they are not at their top level performance, and so it can be more likely that we're going to push into a sensitive symptom range, or they're not going to be able to tolerate rep max testing. And so when we have the ability to use objective testing, it can be good, like the rep max stuff. But when we are in a rehab situation and somebody has symptomatic presentation, it's a little bit better to use something like subjective intensity, where we ask, is this easy, medium, or hard? Or we explain the RPE or the RIR system to them, and we use that rather than trying to draw that line in the sand, which is at a very high intensity or can be very fatiguing. Even after rehab is done, things can still be a little bit tenuous when it gets to getting back into training. As we move from the rehab space into the training space, we want to keep things loose and flexible again, because we know that the line is not linear when it comes from getting to our initial evaluation all the way to return to sport. There are ups and downs even after rehab, and giving them that ability to be flexible and to wiggle within the training can be very good, again, for that long-term outcome as far as trying to be comfortable with training, trying to have a good relationship with training. And we also know, and this is for a different video, when it comes to proximity to failure, or how close we are to failure, we don't really need to go all the way to failure to reap the benefits. When it comes to strength, we can say between like a 6 and an 8 on the RPE, or a 4 and a 2 on the RIR scale. But again, not important right now. All we need to know is that the RPE and the RIR and any subjective intensity measure gives us that wiggle room that we really need when we're trying to figure out our way from that initial evaluation where people are very symptomatic all the way to return to training or return to meaningful activity when they are less symptomatic or not symptomatic. Now, if you're new to using subjective intensity or your patients are new to using subjective intensity, my recommendation is to do the easy, medium, or hard scale, meaning that you ask your patient while they're doing something, is this context, whether that's the volume, the movement variation, or the weight, is this easy, medium, or hard? Now, this takes out the need for explaining the 0 to 10 numeric scale and proximity to failure and what failure actually means, and it just really streamlines it into, is this easy, medium, or hard? They're gonna know what that means. If they say this is easy and I feel great, we can bump up the weight or we can bump up the volume or adjust the periodization however we want to. If they say this is medium, we can be like, okay, that's pretty good. How are your symptoms feeling? How are you feeling about this? If they're saying this is really hard or I'm not having a good time, we can bump things down. And so the easy, medium, and hard scale can be a nice way or a nice foot in the door to subjective intensity in the clinic if you or your patients are not really sure about it. If you like this video and found the information helpful, go ahead and watch my other video on perfecting movement or perfect movement. I think it pairs really well with the subjective intensity talk that we had today. And as always, if you found this helpful, go ahead and share it with your friends, your family, or your patients. It really helps with getting the word, the strong word, out there to as many people as possible.